Next speaker up is my intramural colleague and friend, Susan Resnick from the National Institute on Aging, whose talk is Cognitive Resilience in the Face of Pathology. Susan.
Thank you. I'm going to just go right into it. So again, thanks to the organizers for inviting us to present our work today. What I'd like to do is give a few examples of threats to successful cognitive and brain aging, kind of tying in with the session, talk about a few potential modifiers and predictors of cognitive aging, and then end with some suggestions for strategies to investigate factors that promote cognitive resilience despite pathology. So at the beginning of my talk, I'm going to focus primarily on data from the Baltimore Longitudinal Study of Aging and the neuroimaging study that we've been doing since 1994 as part of our program on early markers of Alzheimer's disease and cognitive decline. The original sample started with about 160 men and women aged 55 and older who didn't have prior neurologic or severe cardiovascular disease. But in 2009, we had the opportunity to extend the MRI portion, and they were already getting cognitive testing and the full BLSA workup, but we've extended the MRI portion to a large sample of the BLSA. Today, what I'd like to focus on are some of our volumetric data from the MRI studies, our PET amyloid studies, and also the cognitive assessments. So what are the threats to successful cognitive and brain aging? Now, to be a little provocative, being male actually in our studies has been one of the threats that's associated with a higher risk for both cognitive and brain aging. Now, we all know that women are disproportionately affected by Alzheimer's disease because perhaps, a lot of it's due to the fact that they live longer. But women have a higher prevalence of the disease and also, assume a higher role in terms of caregiver burden. But when we look at sex differences in cognitive aging, in people who've maintained cognitive health, who are not impaired, what we find are the predicted effects where if we look at the level of performance, men show lower mental status. Men are in blue, the women are in red in case it's harder to see the labels. They show lower mental status, they show lower verbal memory performance overall, but the men show higher performance on a visual spatial rotation task, much as we would expect in the literature. But what was surprising to us, because we assumed that if women were indeed at higher risk early on for Alzheimer's disease, they should show steeper rates of cognitive decline. And in fact, what we found was that men showed greater decline in mental status over time, steeper trajectories of decline on the digit symbol substitution test, a measure of executive function and psychomotor speed, and steeper declines on measures of visual spatial performance, even though they started out with higher levels of performance overall. Now, this is based on a very large sample of, depending on the test, between 1,000 and 2,000 individuals with up to 9,000 assessments over time on these individuals. Now, I mentioned that we've had the opportunity to expand our MRI volumetric studies, and these are very new data. What we found is that there are sex differences also in brain aging. And as I mentioned before during the discussion, with these data, we have the opportunity to exclude data points after the onset of cognitive impairment. So not even just diagnosis, but as soon as there's any overt symptom onset. And what we found here, again, was that for measures of total brain, gray matter volumes, white matter volume, and for hippocampal volume, that there were steeper declines of volume loss in men overall compared to women. And this actually was fairly widespread. I'm showing just a few examples of regions, but we found this across many regions of the brain. This was based on close to 700 individuals. About a third of them only have cross-sectional data. But we've now harmonized data over the years and have more than 2,000 scans. And the harmonization was done with my colleague Christos Stavratsikos. So you've already heard about another threat to successful cognitive and brain aging, being an ApoE4 allele carrier. And you can see that on the on the right, the E4 plus has much more amyloid burden measured with PIB-PET compared to the E4 minus individuals, and these are group averages. But we've had the opportunity to follow these people since 2005, and we've continued to enroll individuals. And this shows a current snapshot of the longitudinal trajectories of brain amyloid accumulation. And I want to make a couple of points. One is that if you look at the individuals, even individuals who are very old, appear to maintain stable levels of amyloid. So it's not the case that everybody within the normal human lifespan will start to accumulate this pathology. On the other hand, there are about 30% of cognitively normal individuals who show substantial levels of amyloid accumulation. And these are not in the range of Alzheimer's patients. These are much lower than you would see in individuals who have cognitive impairment. But what we find is that once people reach a threshold represented by the dashed line, they're on an upward trajectory. And so I think that has a lot of implications about how we think about cognitive change in otherwise healthy individuals, that even at these earliest levels, we know that these people are going to go on and begin to accumulate amyloid. And the other point I want to make is that if we look at E4, one of the things that's happening in the E4 positive individuals is that these individuals show an earlier onset of amyloid accumulation, consistent with the earlier timing of onset of overt clinical disease. And so when we think about things that can maintain cognitive health, if we can shift that onset of amyloid accumulation, that may also help in our attempt to maintain cognitive health. But I did want to show this because one of the things that we've observed is that if we look at the regional pattern of increasing amyloid over time, and I'll run through that again, the regional pattern is very consistent in late onset Alzheimer's disease. Once it starts, it accumulates throughout the brain in a very consistent pattern with early effects on the precuneus, inferior frontal, lateral temporal regions. Now, what's the association between this amyloid deposition and cognitive change over time? So in our early studies, we had cross-sectional estimates of amyloid accumulation, and we looked at that with retrospective cognitive change over the approximately 10 years preceding up to and concurrent with the first PIB scan. And what we found was that if we grouped these individuals into tertiles, there were very clear associations between the estimate of amyloid burden and longitudinal change. So people who had high amyloid levels or high PIB levels showed the steepest declines in verbal memory over time. On the other hand, in people who had the lowest levels, we actually saw the practice effect because we give them the same test every year. Now, that was a bit of a puzzle to us because previously we had found in our autopsy studies in the Baltimore Longitudinal Study of Aging that about 30% of people who are cognitively normal come to autopsy with sufficient levels of amyloid and tau pathology in the brain at autopsy to meet criteria for Alzheimer's disease at pathology. And so we went back to the ante-mortem cognitive data, and what we found was that the Alzheimer's patients, represented by the solid line, showed the expected memory decline in the preceding years up to the time of death. But this group that was asymptomatic, represented in the longer dashed line, that we called asymptomatic AD or high pathology controls, showed no evidence of ante-mortem cognitive decline. So we had this sort of conflict between the in vivo imaging studies and the post-mortem studies. And so one of the things I like to emphasize in the in vivo studies, we think that it's partly due to heterogeneity. In our in vivo studies, we have people who are going to go on to develop Alzheimer's disease, but we also have that group that's going to be resilient. And so one of the things that we want to be able to do is to better understand resilience by understanding the factors which lead to being able to tolerate high amyloid burden but not go on to develop cognitive decline. Now, to give some idea about what we found, we tried to better understand this asymptomatic AD group. And one of the things that we found was that they had higher nuclear volumes in both the anterior cingulate and the hippocampus, but not in the cerebellum. Now, we don't know if that's part of the protective or compensatory process that's allowing these individuals with pathology to remain cognitively healthy, but it could be an inflammatory process or a reactive process as well. And so these are the kinds of things that we think will be important to study going forward. And finally, I know Antonio Terracciano is here, and when he was at NIA, and he's still continuing to work with us, he looked at these individuals who had come to autopsy and were defined as either normal, this asymptomatic AD group, or AD patients, and using personality data collected 15 years before, he found that lower neuroticism and higher conscientiousness were different in the asymptomatics versus the AD. So the individuals who were asymptomatic had lower neuroticism scores 15 years before, and they had higher conscientiousness scores 15 years before on average. So, I think that, again, we're trying to extend that and see what is it about these personality factors that may allow them to be resilient. And just as an aside, conversely, in a separate analysis, he found that high neuroticism and low conscientiousness predict risk for Alzheimer's disease as well. So in the last few slides, I wanted to just give some highlights from a paper that came from the Women's Health Initiative Memory Study, and I know Steve Rapp is in the audience, and Steve and Joe Govius led this paper from the WHI, and it was a series of papers that focused on the women in the study who had made it to 80 years and older at a single point in time. And in this analysis, because we looked at people across multiple organ systems, we defined the group as a common group of the 80-plus cohort, but we actually have more women that we'll go back and look at in the sample as a whole. And what we found was that if we asked, what are the predictors of preserved cognitive function, and in this case, it's really just comparing women who developed impairment versus preserved cognitive function, so it's really the inverse of what we're usually looking at. And again, we found that preserved cognitive function was associated with better education, higher income, lower depressive symptoms, higher emotional well-being, for some reason, more insomnia, which we don't really understand, higher use of lipid-lowering medications, and not being an ApoE carrier, which is consistent with what we know. But in a sense, the more interesting question was in a follow-up analysis, and that was, what are the predictors of optimal or preserved cognitive function, of resilient cognitive function? And this analysis focused on comparing the women who had preserved cognitive function but actually maintained high cognitive function over time versus lower cognitive function. And in this case, it was defined by a modified TIC score of greater than or equal to 39 on the follow-ups that we had. And in this case, again, we find that education is associated with the high optimal functioning group. And also, of course, age and emotional well-being, and in this case, physical activity came up. What's interesting is that ApoE genotype did not come up in this analysis. So ApoE genotype seems to be related to risk for impairment, but is not as a robust predictor of cognitive change within the normal range of performance. So I just want, yes, thanks. And so on my last slide, I just wanted to suggest a few strategies that we've been working on to try to study resilience in the face of pathology. First, Ante-mortem, post-mortem studies of people with pathology who don't develop cognitive impairment, I think, are really key, and we're trying to look at those across a number of different collaborative studies. Secondly, I think the prospective molecular imaging of AD pathology has really given us a lot of insight into the course of this disease, what's happening in this preclinical period, but we know that some portion of those people are going to go and live out their whole lives without developing any impairment. And we need to better understand the factors that predict impairment on the one hand, but then also those who maintain cognitive health. And then the last strategy, I think Ozioma talked a little bit about this, is to study people like ApoE carriers, who Alison Goat has called escapees. So the ApoE4 positive escapees who reach old age but don't develop impairment. And we're actually trying to do that through the Women's Health Initiative. We have a large sample who've made it to 80 plus, who are ApoE carriers, and we have baseline data going 20 years back, and we're going to try to look at those women. And then finally, I just wanted to thank my many collaborators at the NIA, at Hopkins, where we collaborate on the PET studies, University of Pennsylvania, and WHIMS. Thank you.
Hi, that was great. Not to take on the whole amyloid hypothesis in a question or anything, but 30% people with full-blown disease without symptoms at death is pretty significant. I was wondering if if it's maybe not necessarily a resilient story, but we're barking up the wrong tree story, and B, do you see the opposite? Do you see people who are along the course that looks like AD but do not have the pathology as well? And if so, what proportion, and what does that tell us about
Right, so I think our accuracy, Madhav and I have looked at this before, is about 80%. Now, in response to your first question, I think that, we don't understand, and I think the prospective studies will let us better understand how amyloid and then tau kicks in and, where things are going. But I do want to emphasize, these people had moderate levels of pathology, so they also, had Brock scores in the moderate level. So they had tau as well as amyloid. I didn't have time to talk about this, but I'm glad you brought it up, is obviously that we know that the people who are more resilient don't have a large vascular burden. Right. And that's something I think Yakov mentioned again, or other people were, Naftali as well, multimodal imaging. We're actually acquiring now, a full MR series as well as the PET studies, and working with Christos Stavratsikos to try to develop these multimodal staging classification systems.
Thank you.
Susan, that was a great talk, and I was curious about how, what your plans are to handle the problem of survival bias in your survivors. I think this is going to be an issue for everyone studying resilience, especially up into the ages that you proposed in the women's study.
Right. So I think that's a really key factor. And, one of the things that we do have is we have a fair amount of baseline data, and we can try as best as we can. We know that the survivors are healthier, obviously, and we have to look at a variety of different covariates to try to better understand how those relate to the brain characteristics, the cognitive characteristics, in order to I'm not really saying this very clearly, but basically, if we can look at the covariates and understand what the factors are, those covariates, those comorbidities are the reasons people drop out. And so to try to account for some of the comorbidities as we go. But you're right, that is a bias, and that's something that we'll have to deal with.
I see a lot of positive and optimistic messages from your presentation. Thank you very much. In one of the slides, you showed the change of verbal memory over age. And I found the normal control group, actually their verbal memory increased substantially as they aged. I just wonder whether you have any comment on that. I wish I could be a part of that group.
So there's a little bit of a caveat there. The caveat is that in the particular summary slide that I used here, you see the verbal memory increasing. But I don't want to go all the way back to the beginning of the slides, but if you look at the slides on sex differences, that initial advantage kind of peters out the older you get. So I'm not saying the practice effect goes away, but the magnitude of the decline overwhelms the practice effect in older people. So in the youngest people, you see a substantial practice effect. Around the 60s, it kind of plateaus, and this is on memory tests, kind of plateaus in our sample, and it gets a little flat. And then by the time you get to the 80 and olders, you really see more decline than practice. And that's even though we're giving them the same test every single year. So I have people who will greet me at the door and recite the word list from the California Verbal Learning Test to me when they come in because they've probably had it about 15 times. But I don't really worry about that because when they start to develop impairment, they start to decline. And in some age groups, the absence of that practice effect may actually be a measure of cognitive impairment.
I have a question about the education effect, which is very consistent with other studies. Say the higher attainment of education, the more protective you get. My question is about the measurement of education. So far, education has been measured by schooling years or highest degree of education. I just wonder if we can measure the additional potential additional effect of continuing education and lifetime learning, rather than just say by a certain age, what's the highest degree of you have?
Right, and I think Jennifer Manley's here and can speak to some of that on quality of education as well. There you are.
Sanjay,
Hi, Susan. Yes.
is it very quick?
Very quick. Susan, I just wanted to know, your very interesting data related to sex-based differences in brain volumes and cognition. I wonder if you think that, at least in part, that may be due to X and Y chromosomes, okay? In other words, the Y chromosome increases risk and X chromosome confers resilience. Is that possible?
I don't know. I don't think I can say that from our data. I can't say that from our data. You know as well as I do that it's all very complicated because we have hormonal effects both early in development and throughout life that affect those as well. So,
yeah, sure. I think there's some emerging animal data that may have suggestion that X and Y chromosomes play an independent role in terms of risk and resilience to Alzheimer's and other cognitive changes with aging.
Yeah, I think one confusing thing is, as you know, the X chromosome inactivation will also complicate trying to study that.
Sure. Thank you.
Terrific. Thanks so
Thank
much,
you.
Susan.